Directed. Yeah, that's right. Got it. Okay. It's directed to the podocyte is a central pathogenic factor in both FSGS and minimal chain disease. So before going to the morphology proper, we should know what is the basic structure of podocytes and what is the basic mechanism involved in the podocyte injury causing this condition. So we know that the nephron is the basic structural and functional unit of the kidney. So it comprises of glomerulus, proximal convoluted tubule, loop of Henle, distal tubule, collecting ducts, and finally it drains into the renal pelvic calyceal system. So this is just, I mean, a zoom of the glomerulus. We can see the apparent arteriole and forming glomerular capillary, and it is. So if you see the glomerular capillaries, okay.
Can everyone please mute themselves? Can everyone, all the attendees, can you please mute yourself?
Issue is that, I mean, so I think you can mute.
Yeah, just hang on a minute, Aravind. Let people mute themselves.
Hello, Shay.
Issue?
Yeah, please proceed.
Yeah, okay, sir. Thank you, sir. So, okay, so if you see, this is the, I mean, the schematic diagram of the glomerulus, and this is the glomerular capillaries. So if you see the glomerular capillaries, so it comprises of basement membrane, and these are the fenestrations of the endothelial cells, and outside it is covered by the food process of the podocytes. Okay, so here we can see in this schematic diagram, the podocyte has several processes: primary processes, secondary processes, and finally this tertiary processes will come and over the glomerular capillary wall, and it covers, I mean, completely and entirely. Okay, so this is the basic schematic diagram of the podocytes, how it covers the glomerular capillary wall. Okay, so one should know that the podocyte is a terminally differentiated epithelial cells. Okay, so what do you mean by terminally differentiated epithelial cells? So in normal condition, it lacks the proliferative capacity. Okay, now so it is a terminally differentiated. Already it is differentiated completely. So it covers the surface of the glomerular tuft. So it has large cell body from which primary processes emerge and give rise to highly ordered system of interdigitating food process bridged by the slit diaphragm. So the slit diaphragm is also very important to understand to know the pathology of. So the slit diaphragm, along with the podocytes, which plays an important role in the regulation of glomerular filtration. So this function of glomerular filtration is carried out along with the other layers like endothelial cell layer, glycocalyx of the endothelial cells, and glomerular basement membrane and subpodocytic processes. So this is the ultrastructural view. So one can see, so this is the podocyte, the nucleus of the podocytes. So from these podocytes, there are processes arising. So primary processes, secondary processes, and finally the food processes coming and impinging on the glomerular basement membrane. So this is just high power of the food processes. So we can see, so these are the food process of the podocytes, and between the food processes, we can see the slit diaphragm. Okay, so this is the slit diaphragm, and this is the basement membrane, and these are the fenestrations present in the endothelial cell layer. So the slit diaphragm is also important. There are many molecules comprises this slit diaphragm, starting from the nephrin. Nephrin is a major component of the slit diaphragm. So here we can see the pair of nephrin molecule extending out into the center of the slit from the adjacent podocytic food processes. And the second important molecule is podocin, which forms an hairpin turn within the podocyte membrane. And through interaction with the CD2AP protein, and the slit diaphragm molecule are linked to the actin, okay, which is regulated by alpha actin 4 gene. And at the basal surface also there are some molecules like alpha 3 beta 1 integrin and alpha dystroglycan that helps in linkage to the underlying glomerular basement membrane. So one should know molecule involved in this slit diaphragm of the podocyte. So for the normal function of the podocyte, it depends on this highly ordered cellular architecture. Okay, so the injury of either of these molecules affects the podocyte function and it may cause proteinuria. So the podocytopathy are the group of glomerular diseases in which proteinuria is attributed to damage or dysfunction of the podocytes. So this damage can come from inherent, that is inherent to the podocyte itself due to genetic causes, or it came from some extrinsic factors. So there are several, intrinsic causes described in the literature. So including, so whatever the molecules I described, so the mutations can happen in those in any of those of the molecules, like starting from WT1, PAX2, LMX1B mutation, and cytoskeleton structures like actin 4 mutation, and slit diaphragm complex NPHS1, NPHS2, CD2AP mutations, and plasma membrane molecules. So these are, some molecules involved in the genetic causes of podocyte injury. So there are several extrinsic causes also, starting from virus, the most common, the infections, or circulating viral protein, and there are some toxins like medications like pamplitronate, interferon, puromycins, aminonucleosides, adriamycins can also cause podocyte injury. And the most common factor, explained in the idiopathic causes of FSGS is circulating permeability factor. Okay. And there are some immune complex deposition or in situ formation, as in lupus, IgA nephropathy, membranous nephropathy can also cause podocyte injury. So, so whatever may be the cause, so there are several causes of podocyte injury. So whatever the cause may be, the stereotypic response of podocyte injury is food process effacement. Okay, so the final the response is food process effacement due to reorganization of actin filament. So this food process effacement leads to proteinuria. So these podocytes reacts to injury. So usually the major response is observed following injury to the podocytes, and subsequently the 4 major histological types were observed on light microscopy. As a result of podocyte injury, these podocytes can undergo only phenotype modification. So only structure will only undergo modify. So it results in there is no change in number. So it manifests as minimal change disease on histology. The podocyte injury may cause apoptosis of podocytes. So it may lead to detachment and podocyturia. So this type of response may lead to segmental sclerosis on histology. And finally, as a result of podocyte injury, this podocyte will undergo developmental arrest or de-differentiation. As I already pointed, podocyte is a terminally differentiated. But as a result of injury, so the de-differentiation may occur. So it may lead to re-entry into the cell cycle. So as a result of podocyte proliferation, the two morphology is frequently observed on the light microscopy. So one is collapse in glomerular body and other is diffuse mesangial sclerosis. So we will see the each morphology one by one, and we can discuss the causes also. So starting with minimal change disease. So what do you mean by minimal change disease? As the name implies, so that minimal change or no change. So we will not see any changes in the light microscope. Okay? The glomeruli will be normal. So here we can see that. So just I can see the normal morphology. So glomerulus. Here this is the Bowman's capsule. So this is parietal epithelial cells. So this is Bowman's space, and this is glomerular capillaries. Okay. So in case of minimal change disease, the glomerulus is absolutely normal. Okay. So we can see the normal glomerular capillary loop, and these are mesangial cells. So this is mesangium. So up to 3 cells are normal in the mesangium, and there is no segmental sclerosis, or there is no proliferation of endothelial or extracapillary cells. So in minimal change disease, the light microscopy is okay, but we will see change on electron microscopy in form of extensive podocyte.
Sorry, Aravind, can you? Yeah, go ahead.
Oh, okay, sir. Now it's okay. Yeah. So the changes only will be observed in electron microscopy. So in form of extensive podocyte food process effacement, and actin condensation will also be seen. So this is the electron microscopy picture of a minimal change disease. We can first concentrate on this insert diagram. Okay, this is absolutely normal. So we can see the glomerular basement membrane. That's 3 layers: lamina densa, lamina rara externa, lamina rara interna. Okay, so there are 3 layers, and here we can see the nice food processes. Okay, like cylinder like processes is just sitting over the glomerular basement membrane, and in between the food processes there is slit diaphragm. Okay, so this is normal. Okay, so coming to this main picture here, so what is difference between this insert picture and this? So we can see that the podocyte is completely effaced. Okay, I can't able to see the food processes, so it is completely effaced over the glomerular basement membrane. So this electron microscopy finding will be observed in cases of minimal change disease. So the podocyte injury in minimal change disease may be idiopathic, genetic, or reactive. Okay, so this is some of the causes of minimal change disease. It could be the mutation in NPHS1 or NPHS2, and there are some studies has shown that this minimal change disease has been linked to a nearby locus on chromosome 19q, for which the gene remains identified. And this is the another mutation which can also cause minimal change disease. This very. So the peak age is usually 2 to 4 years, but one should know that the adults are also equally affected, and the male-female ratio is 2:1. So usually this minimal change disease present with nephrotic range proteinuria, and the renal functions remain intact. And the proteinuria is highly selective, so most protein being albumin. Okay, and usually not associated with hypertension or hematuria. And more than 90% of the children with minimal change disease respond to steroid therapy well. It may recur, and some patients may become steroid dependent or resistant. Okay, the steroid sensitive nephrotic minimal change disease manifests decreased podocyte expression of dystroglycan. So this is based upon one study. Okay, so based upon the expression of dystroglycans, we can say whether this minimal change disease is steroid sensitive or steroid resistant. Okay. So coming to the next morphology, so focal segmental glomerulosclerosis. Okay, focal segmental glomerulosclerosis. So what do you mean by focal segmental glomerulosclerosis? So the name itself is telling. So focal, the focal means that less than 50% of the glomeruli is involved. Okay, so the remaining 50% may be normal. Okay, so focal. So focal in real biopsy means it is less than 50%. Segmental. So what do you mean by segmental? The segmental, the terminology implies to the single glomerulus. Okay. If the less than 50% of the tuft is involved, so we have to say segmental. If there is more than 50%, then that is global. Okay. So focal means less than 50% of the glomeruli. Segmental means in one glomerulus, less than 50% of the glomerulus is involved. Okay. And glomerulosclerosis. Okay. So focal segmental glomerulosclerosis. So here we can see that there is, in the last picture, we saw the glomerulus is absolutely normal. Okay, the capillary loops are open, pattern, but here we can see there is segmental solidification of the glomerular capillary tuft. So why it is solidified? It is due to accumulation of extracellular matrix, and there is some synechial formation between the capillary tuft and Bowman's capsule. So this we can say it as FSGS. So the remaining 50% of the glome is, I mean, absolutely normal. Okay, so there is segmental solidification of glomerular capillary tuft with accumulation of extracellular matrix, and synechial can be there. So this is another picture. So I mean, hematoxylin and eosin stain, and this is, I mean, PA stain. So we are doing routinely for the evaluation of renal biopsy. There is segmental solidification of the glomerulus with some synechial formation. So, so usually the juxtamedullary glomeruli are initially and also more vulnerable to develop FSGS. So this is because, I mean, this juxtamedullary glomeruli has increased single nephron glomerular filtration rate. Okay, so this is juxtamedullary glomeruli is the first glome involved in cases of FSGS. Okay. So the podocyte injury in FSGS can be again idiopathic, genetic, or reactive. So reactive in terms of it can be post-adaptive FSGS or medication-associated FSGS. So you understand the basic morphology of FSGS, like in a focal segmental glomerulosclerosis. So there are different forms of FSGS is there, as I already told. So it can be again idiopathic, and it can be due to some genetic mutation, or it is reactive to some other conditions. So that in cases of idiopathic FSGS, the most postulated cause, I mean, described is the presence of circulating permeability factor. This is so-called soluble urokinase receptor. So this circulating permeability factor causes reorganization of actin cytokeratin. So that may lead to effacement of food processes and segmental sclerosis. And there are many genetic forms are associated. So some are associated, some are, with syndromic manifestation, and some are non-syndromic manifestations. And this FSGS can occur also reactive to reduced nephron mass. In cases of renal dysplasia, surgical renal infection, reflex nephropathy, and chronic interstitial nephritis. So these are some reactive forms of FSGS. So again, whatever cause could be, the common pathophysiological principle is absolute or relative podocyte depletion. So the depletion can be absolute or relative. Okay, so you should know that podocyte depletion is the final pathophysiological principle in causing FSGS. So how this podocyte depletion cause this FSGS, segmental sclerosis lesion. So this is based upon in vitro and animal studies. Okay, so I already told the podocytes are normally completely covering the glomerular capillary. So there will be no direct contact of glomerular membrane with the Bowman's capsule. But what happened when there is podocyte injury and podocyte loss? Okay, so when there is only 20% of the podocyte loss, initially the glome will start glome hypertrophy. So the mesangial expansion is expected. But when there is loss of 20 to 40% of the podocytes, it causes small patch of podocyte depletion and synechial formation between glomerular capillary wall and Bowman's capsule. But when the loss is more than 40%, when loss is more than 40%, there will be complete synechial formation between the capillary wall and Bowman's capsule. So it finally leads to segmental sclerosis. So here I just explained what are the critical events happen in the podocyte loss. Yeah. So as a result of injury, the podocytes may undergo apoptosis and detachment. So it creates the denuded segments of glomerular basement membrane. So initially whatever the remaining podocytes are there, it adapt by increasing the size to cover the newly denuded glomerular basement membrane. So the podocytes initially undergo hypertrophy, but these hypertrophic podocytes may be unable to maintain a normal food processes structures, leading to further increasing local shear stress that triggers further podocyte detachment and loss. So now this the glomerular base membrane is mapped without podocytes. So it has will come and contact with the parietal epithelium. It leads to formation of synechiae and finally leads to segmental sclerosis. If podocyte loss is not replenished, it may lead to further podocytopenia and progressive glomerular sclerosis. So this is the basic sequence of events happening before segmental sclerosis happening. So, there are different, there are 5, different neurological patterns is explained in FSGS as per Columbia classification. So, starting from collapsing lesion, tip, cellular, perihilar. If none of them are observed, so we can keep it as not otherwise specified. Okay. So we will see the each morphology one by one, and what is the importance of each morphology, we will see. So starting with collapsing variant, collapsing variant. So what do you mean by collapsing variant? So here we can see the, okay. So here we can see, so the capillary tuft is completely collapsed. So I can't able to see the capillary lumen. Okay, so the capillary tuft is completely collapsed. We can see the wrinkling and folding of capillary wall. So this collapse should be present at least in one glomerulus, at least in one glomerulus. So it qualifies for collapsing variant of FSGS. Okay, so this collapse is usually accompanied by podocyte hypertrophy and podocyte hyperplasia. Okay, so podocytes hypertrophy bhi ho raha hai, so podocytes hyperplasia bhi ho raha hai. Okay. So, sometimes it may mimic crescents. So we should know how to differentiate this collapsing lesion from the crescents. So we can differentiate based upon the presence of fibrin in the, if you are seeing fibrin, so that means the capillary wall is ruptured. So that is the crescent. In case of, collapse, we usually will not see fibrin in the bone space. The most, example of collapsing variants are idiopathic. But this collapsing variants is also, commonly described in HIV, HIV-associated nephropathy, and other associations include parvovirus B19 infection, SV40 infection, cytomegalovirus infection, interferon therapy, pampidonate toxicity, and it can also be seen in acute vaso-occlusive injury, including thrombotic microangiopathy. So this collapsing variant is present with severe nephrotic syndrome and usually not respond to the steroid therapy, and it may present with a rapidly progressive renal failure. Okay, so this understand the collapse. So we can see the mitotic figures also. Okay, so so there are, again, several causes of collapsing glomerulopathy. In case of idiopathic collapsing glomerulopathy, it is characterized by dysregulated phenotype. Okay, dysregulated phenotype. So as again, I have to stress that the podocyte is a terminally differentiated cell. But in case of idiopathic collapsing glomerulopathy, what is happening? So the phenotype is, so it is manifest by loss of liquidity. So, the synaptophoiding podocalcin GLP-1 CALA expression in the podocytes, and it's restart expression of immaturity markers like PAX2 and cytokeratin. Okay, so this immature podocytes re-enter the cell cycle and proliferate. Okay, usually podocytes will not proliferate, but in case of collapsing glomerulopathy, so this podocyte, because of this dysregulation, this podocytes re-enter the cell cycle and start proliferating. So the K67 is a usual immunomarker, so we can assess the podocyte proliferation in cases of collapsing glomerulopathy. So moreover, the podocyte lost the expression of WT1, a transcription factor that is normally expressed by the podocytes. So there are some genetic causes described in collapsing glomerulopathy, like mutation in coenzyme Q2. And as already I told, and it is described in HIV infections and other viruses and drugs like interferon and pampidronate. So, and some authors also prefer the term collapsing glomerulopathy rather than collapsing FSGS, because usually, sometimes we won't see the segmental sclerosis part in the collapsing lesion. So the collapsing glomerular body may be the better terminology than collapsing FSGS. So the second morphology of FSGS is tip lesion. Okay, tip lesion. So to say tip lesion, first you have to identify tubular pole. So what do you mean by tubular pole? Again, one can see this is the again glomerulus. Okay, here we can see this is the hilum. Okay, this is the afferent arteriole. So the pole just opposite to the hilum is called tubular pole. Okay, so this is the hilar region. The pole just opposite to the hilum is called tubular pole. So this is the tubular pole. Okay, so what we
Arvind,
can see.
Arvind, do you mind converting your pointer, converting your mouse pointer into a laser pointer?
Yes, sir. Just now fine, sir.
Yeah, this is much better. Thank you.
Thank you, sir. So, okay, what we can see here is, so this is the hilar region. So the pole just opposite to the hilum is the tubular pole. Okay, so this is the tubular pole. To say tip lesion, okay, first we have to exclude the collapsing variant. Okay, so that is the main thing. To next thing, so we have to see at least one segmental lesion involving tip domain. Okay, so this is the tip domain. So we can see the segmental sclerosis in the tip domain. So we can say this lesion as FSGS tip variant. Okay. So this only I described here. So the tip domain is the most peripheral portion of the glomerular tuft next to the origin of the proximal connected tubule. Okay. So the lesion must have either an addition or confluence of podocytes with parietal or tubular cells at the tubular lumen or neck. Okay, either segmental sclerosis should be there or just confluence of this podocytes with tubular epithelial cells or parietal epithelial cells should be there to say FSGS tip lesion. Okay, and this is another picture. We can see that prolapse of glomerular capillary loop into the proximal convoluted tubule. Okay, so this is the classical tubular lesion, and we can see the intraglomerular foam cells also within the capillary lumen. So usually this FSGS depletion is primary, okay, but it can be seen in some other conditions also. Yeah. So, so this depletion usually present with the full nephrotic syndrome, full-blown nephrotic syndrome. So the proteinuria will be severe in these cases, but the prognosis is very good. So it's a favorable outcome with very less tubulointerstitial injury, and this lesion respond to steroid better, okay, compared to the other histological variants. So coming to the third morphology, okay, cellular lesion. Okay, to say cellular variant, we have to exclude collapsing variant and tip variant. Okay, so that is the primary thing. So in case of cellular lesion, what is that? So name is spelling is cellular. Okay, cellular. So here we can see there is segmental endocapillary hypercellularity completely occluding the lumen. So these cells may have foam cells. Okay, here we can see there are intraglomerular foam cells completely occluding the glomerular. So this cellular lesion is usually primary. So again, we don't know the cause in the cases of FSGS cellular variant. And in many cases, it may represent early stage in the evolution of sclerotic lesions. Okay, so this might be, so many authors suggesting that, so this could be the early event in the evolution of sclerotic lesions. If we are repeating biopsy after, some years, some other variant may be there. So that is the point. Okay, so it represents the early stage evolution of sclerotic lesions. So coming to the fourth morphology, so called perihilar. So this is just opposite to the tip. Okay, perihilar. Okay, so again the name itself. So the lesion should be around the hilum. Okay, around the hilum. So segmental sclerosis. Here we can see that the segmental sclerosis and hyalinosis involved in the vascular pole. Okay, involved in the vascular pole. So this is the hilum. We can see the afferent arteriole, and this is the tubular pole. So here the segmental sclerosis is hyalinosis involved the vascular pole, and this lesion is usually accompanied by glomerulomegaly. Okay, it is usually accompanied by the glomerulomegaly, and this is the common type of lesion observed in secondary adaptive form of FSGS. Adaptive form of FSGS such as obesity, hypertensive nephrosclerosis, and in cases of renal agenesis, reflex nephropathy, when the in transplant kidney. So in transplant kidney only there is single kidney. Okay, so that is also one form of adaptive thing. So in those conditions, this perihilar lesions can be there. So again, to say perihilar variant, we have to exclude collapsing, tip, and cellular variants before considering the perihilar variant. Okay, so we saw that, I mean, 4 different morphology. If you are not seeing any of this morphology, we can simply label that case as FSGS, not otherwise specified. This table highlight the different clinical features of these variants. Some of them as already described. So the variant which with worst prognosis and poor response to steroid is collapsing variant. The variant with good prognosis is tip variant. Okay, so that one I should know. And perihilar variant is usually seen in adaptive form of FSGS. Okay, so and this is the, I mean, another form of, I mean, FSGS. I mean, usually, I mean, encountered in congenital or infantile nephrotic syndrome, so called diffuse mesangial sclerosis. Okay, so diffuse mesangial sclerosis. It is defined by mesangial expansion as a result of accumulated extracellular matrix protein together with podocyte hypertrophy and mild hyperplasia. In contrast to FSGS category, the lesions that are assigned to DMS shows relatively de-differentiated or less differentiated podocyte phenotype. It occurs in syndromic form or sporadic form, so both of which tend to be refractory to therapy. So the congenital DMS is associated with the WT1 mutation, and in syndromic form, the Dennis-Nash syndrome. And mutation of LAM2 encoding laminin 2 chain can also cause DMS form of histology. And familial form of DMS, that is possibly truncated mutation of phospholipase C epsilon receptors. So in both forms, there is increased expression of proliferatory markers such as Ki67 and increased podocyte expression of cytokeratin, reflecting de-differentiated phenotype. So again here, the basic pathology is de-differentiation. But in contrast to collapsing FSGS, the expression of other podocyte maturity markers such as synaptophyrin, nephrin, alpha-actin 4 is preserved in DMS. So, okay, so till now we saw the different morphology. So based upon the morphology also, based upon the morphology and onset, time of onset of nephrotic syndrome, so we can suggest the particular genetic testing in an individual. Okay, so suppose these are the few examples. So if you are seeing some dilatation of proximal tubules, so this could be due to NPHS1 mutation. So we can ask for that genetic testing. And this minimal change, this is FSGS in congenital onset. First, we have to work up for NPHS2 followed by NPHS1, and DMS as already told. So WT1 mutation and phospholipase C epsilon 1 mutation. So these are the different histology and the different accompanying different genetic mutation approach. Okay. So this is just, I mean, this article just, I mean, highlight the different clinical presentation and outcome of FSGS variant. So as already told, the tip variant is the good prognosis. Here we can see in 76% of the cases, the 3-year renal survival was observed, and collapsing is the worst prognosis. Only in 33% of the cases, there was complete remission in 3-year renal survival. So okay, so I mean, this FSGS can also recur after transplant. So 20 to 30% cases were on transplant. So young age, I trace the rapid progression to end-stage renal disease. Live related donors are the risk factors. Recurrences usually occur very early, that is before 3 months, and so that is, I mean, obviously due to circulating permeability factor, and often within first 48 hours. So yearly recurrence provides strong evidence for role of circulating permeability factor in FSGS in the recipients. Okay, so that's all for today. Yeah. So if you have any doubts in the morphology, I'll take.
Thank you, Dr. Aravind,
Thank you
for that very careful presentation in detail about the basics of the histopathology, etc. So I would request now Dr. Ritambhra again to perhaps add her comments, and also all of you, please, if you have any questions, feel free to ask your questions in the chat, or unmute yourself, raise your hand, and go ahead and ask your question.
Okay. So as Dr. Aravind has mentioned, that basically while interpreting these biopsies, what is most important for anybody to understand is that these biopsies are going to be immunofluorescence negative. In a patient who has nephrotic syndrome with the IF negative, that is when we are going to consider a diagnosis of podocytopathies, which include minimal change disease and FSGS. And since FSGS, Dr. Aravind mentioned that these are focal and segmental, that means less than 50% of the glomeruli are involved, which means the first cut may not show us any evidence, morphological evidence of any injury. So as a pathologist, we always take multiple sections to rule out presence of any abnormality in any part of the biopsy which is examined, right? So we do not give a diagnosis of FSGS unless we have done serial sections and excluded any segmental pathology. Sometimes, even if you don't see glomerular sclerosis, you may have an area of tubular atrophy, which is out of proportion to the damage expected for that age. In that situation, we can suggest a possibility of unrepresented FSGS, because it being a segmental process, it may not have come in that particular small piece of biopsy which we have taken, right? Then Dr. Aravind did mention about different variants, and they have their clinical counterparts, which means that collapsing, generally having a heavy proteinuria, TIP variant almost behaving like a minimal change disease, Perihilar being mostly in a secondary setting, which means they may not require a classical or your typical immunosuppressive therapy. So these are the importance of classifying these segmental lesions, right? And foremost, though it is difficult to say, in absence in situations where we don't have electron microscopy, we may miss out certain conditions like Alport syndrome presenting as FSGS. So in that scenario, what is recommended is that if the patient is not responding as you expect for FSGS, in that situation, you may refer the block for electron microscopy, as EM can also be done from paraffin embedded tissues which are submitted for light microscopy. So monitoring patients for response of therapy, and if it does not happen the way you are expecting, one of the reasons could be a hereditary basement membrane disease like Alport's, and even sometimes metabolic diseases like your Fabry's disease also, if in advanced stage, can present like that. So please keep in mind that EM can be done from paraffin tissue as well, right? So I think that is the whole gist of our today's lecture.
So, Professor Nada, just a couple of clarifications. You said that minimal change and FSGS biopsies are typically immunofluorescence negative.
Yeah.
But in FSGS, can we see sometimes some non-specific immune deposits? Do they kind of rule out the diagnosis of FSGS if they are present?
Yeah, so this is a very kind of, this point is very important to emphasize, is that many books, many articles would mention presence of IgM or C3 in FSGS. But these deposits, when they are talking of entrapment of these IgM and C3, which is very commonly happens in any sclerotic area. So sclerotic tissue entraps IgM and C3. So that is not a typical immunofluorescence positivity. When we talk of immunofluorescence positivity, as we learned in last lecture, that it has to be patterned either in mesangium or along the basement membranes. So if it is present as a blob in area of scarring, that is not interpreted as being positive. Though I agree that many papers and many books do mention presence of IgM or C3 in FSGS being there, but that is basically in the scarred area or the sclerotic areas.
Thank you. Just one more question. Can you give all of us some tips on how to differentiate primary from secondary FSGS on examination of the biopsy tissue? Dr. Both you and Dr. Aravind did point out that hilar lesions may indicate that, but are there any other tricks both for light microscopy, immunofluorescence, and electron microscopy to make that distinction?
Yeah. Aravind, you want to take, or shall I take it up?
Yes, ma'am.
Okay.
I will just restate that. So if you are seeing only the perihilar variant, on light microscopy, okay, we can suggest most probably this could be secondary FSGS, and other causes, other tip variants and this collapsing and all. This is described both in primary and secondary causes. And apart from that, we have some differentiating features in electron microscopy also. So with this, I will give to Madam. Madam, you can add it.
So in morphology, generally what we, how we go about practically is that if you are finding interstitial foam cells, which are in absence of very significant proteinuria or heavy proteinuria, that is generally taken as a clue towards diagnosis of it being a hereditary basement membrane disease, Alport's, especially the Alport's. Because generally, only if proteinuria is heavy, then you are likely to have to see interstitial foam cells. So in absence of heavy proteinuria, presence of interstitial foam cells should prompt us to submit the tissue for electron microscopy. And even another morphological clue is that in FSGS secondary to Alport's, the area of fibrosis is generally lateral on the sides of the Bowman space rather than being on tape or in the perihilar region, which looks different from usual FSGS. Another variant, another clue to FSGS in pediatric population is sometimes presence of mesangial proliferation in absence of any immune deposits. That is also taken as being FSGS in progression. Otherwise, I don't think, other than presence of tubular atrophy and interstitial foam cells, there are any ways of kind of getting to the point of it being primary FSGS or due to other causes.
Great, thank you. There is a related question, which from Dr. Nala Alam. Is mesangial proliferation on biopsy an early sign of FSGS?
In pediatric population, yes, I won't say early, but it is considered as one of the variants of FSGS, where immunofluorescence is negative, but patient presents with nephrotic syndrome. Somehow it has been put in FSGS, though there is no segmental sclerosis, but not much work has been done beyond this.
Right, thank you. There is a question from Ugochi. It has been suggested that in FSGS, hypoalbuminemia suggests likely primary etiology, and a normal albumin suggests a secondary etiology. Is this still supported by literature currently? So this is not a histology question, but a clinical question. So I can say that yes, this is one of the ways in which we can accumulate evidence to try and distinguish primary from secondary FSGS. So in addition to other features, if you have normal serum albumin, it is likely to indicate a secondary FSGS, but that's by no means the only evidence that we use to make this distinction. So yes, Dr. Raja, go ahead.
Perfectly fine. Perfectly fine.
One of the questions I see here is that, is there any importance of tubular injury in prognosis part based on pathology of podocytopathies? Definitely yes, because the degree of tubular interstitial damage is now considered as the primary deciding factor, not only in FSGS, rather in all kinds of glomerular diseases, because there is always a glomerular tubular crosstalk. So if you have extensive tubular injury, that is generally taken as being a bad prognostic feature. And if you can go through a review article which deals with how to interpret kidney biopsies. Now, tubular injury is graded on the scale of 25%, 0 to 25, 25 to 50, 52 to 75, and more than 75, just to indicate to the clinician that what is the degree of tubular interstitial damage, because that is what is going to govern the long-term prognosis for any glomerular disease in any setting, including podocytopathies. Another question I read here is that in minimal change disease undergoes remission on treatment with steroid. Does it mean that actin cytoskeleton again gets rearranged and food processes effacement gets back to normal? Answer to this is probably yes, because whenever we see segmental or less food process effacement in minimal change disease or FSGS, it is considered that possibly the patient has been treated before taking the biopsy, because it has been shown in studies earlier that reversal of food process effacement does occur after treatment.
Madam, extending your answer, madam, like, in MCD, now we are aware that, patients have anti-nephrin antibodies. So, once you treat this MCD, the antibodies disappear. So the anti-nephrin antibodies do cause, actin cytoskeleton rearrangement. Once these antibodies disappear, again, it comes back to normal. So yes, the treatment, there is disappearance of this antibody resulting in normal actin cytoskeleton.
There are a few more questions in the chat, Dr. Nara. So one question is the difference between collapsing FSGS due to COVID from other types of collapsing FSGS.
Morphologically, there is no difference in whatever literature has been collected till so far. Collapsing FSGS of whatever etiology, they look alike, except for the fact if we are able to see an occluded arteriole in vicinity, then generally we assume that this is a secondary collapse because of vascular occlusion, which is one of the causes of collapsing FSGS, and probably they behave different than other causes of collapsing glomerulopathy or FSGS. Another question which I read here is, does enlargement of glomeruli points towards secondary FSGS? Answer to this is yes, because in obesity related FSGS, first sign of podocytopathy is enlarged glomerulus. And what we mean by enlarged glomerulus is that in 40x magnification of our microscope, one single glomerulus goes beyond the confines of 140x magnification. So yes, it is one of the clues towards secondary FSGS. Another clue to FSGS is irregular or different sizes of capillary loops in a glomerulus is also a clue towards secondary FSGS.
Great, thank you. There is one interesting question which might also be, might generate some controversy. Shouldn't collapsing variant be removed from FSGS? There is no sclerosis. Why is it grouped with FSGS?
There have been, I think, some debate on this, that it should be segregated. One, because it behaves very differently, and sclerosis occurs when collapsed area heals off. It does present as sclerosis, but it's a different kind of sclerosis. And there has been debate on this, that whether it should be removed, it should be considered as collapsing glomerulopathy rather than a variant of FSGS. Another question relates to consensus on APOL1 FSGS in terms of morphology. To this, the literature says that FSGS due to APOL1 generally has global glomerulosclerosis. Like if you see 10 glomeruli, 2 of them will be completely sclerosed and rest being everything being normal. And in that scenario, we do mention that this is focal global glomerulosclerosis, and patients should be investigated for APOL1 mutations.
Great, thank you. We are coming towards the end of our time, and I was wondering if Professor Ifeoma Olase would like to make any comments.
Good morning, everyone, and good afternoon, those in India. We're very appreciative of this program we have with you. It's a lot of enlightenment for us. You can see so many of us in Nigeria have joined from different areas of Nigeria, so we're very appreciative. And it gives us a lot of understanding of the basics of pathology as regards FSGS and minimal change disease. So thank you, Professor Nada and Professor Ja for this, and Dr. Onu for organizing it, because she has been on it. Thank you so much, Dr. Thank you everyone for joining, especially those from Nigeria. Thank you.
Yes, thank you, Ifeoma, and all the colleagues, and for sure, Wochi Onu. And we will meet again in 1 month's time. We'll share the link with you, and this program will be repeated on every first Friday of every month, as I said before. And we hope to gather around again. Thank you.
Thank you, everybody.
Bye, everyone.
Bye.